Welcome, everybody, to ASCP's podcast, Our Experience. I am one of your hosts, Chad Wurz, alongside my co-host, Tom Hansel, and we're very excited today to have one of our past presidents, Shelly Spiro. She was a president of ASCP. She's also been at the forefront of the Pharmacy Health Information Technology Collaborative, which I'll let her describe. It was started a number of years ago, really to keep pharmacy and pharmacists at the top of the leading edge of technology for practice, something that is maybe not always top of mind, but certainly critical to the future of pharmacy. So, Shelly, welcome.
Thank you.
Oh, I knocked
There goes
down
Boomer. Boomer's
Welcome,
down.
and tell us a little bit about your career, your history.
Sure. I've been a pharmacist for almost 50 years. And I grew up in Las Vegas, went to pharmacy school at UIC. I've been involved, my husband was in the military, so I was hospital pharmacist first and then worked at many military installations, have a lot of Red Cross volunteer hours in.
Nice.
And then I got involved in oncology. I worked for Fitzsimmons Army Medical Center in Aurora. Then got involved, went back to live in Las Vegas and got involved in long-term care. Worked for what was called MediSave out of Baton Rouge, Louisiana. They actually managed the pharmacies in Walmarts before they took it back over, and was in part of their long-term care division. And we did long-term care, home care. We were one of the first pharmacies to go through Joint Commission for home care. And we did, and then I moved to Louisville, Kentucky in '97 to work for Kindred Corporation through several mergers and acquisitions nationally. And so I was a national senior director there. And then left Kindred in 2005. Moved to Washington, D.C. and opened my own consulting firm. And I've been a consultant ever since that time. And in 2010, the National Pharmacy Professional Organizations came together and formed the Pharmacy Health Information Technology Collaborative. And I've been the executive director ever since.
So talk about that time, because again, I want to give all of our members context. It was, and correct me if I don't describe this correctly, but it was a time when there was a recognition that we needed to be at these tables where they're talking about health information technology. Pharmacy needed to be there. And the associations recognized that this was not something that made sense for all of them to do on their own, that they really needed to come together and be an equal force across the profession, which I think in a lot of ways represents the good in some of the pharmacy association world, because we are often aligned, but I think sometimes pharmacists around the country feel like we're all representing our own little niches and sections of pharmacy, and we're not always aligned, but this has always been something where we've been aligned. But talk about the advent of that group.
Sure. So all the professional organizations came together in January 2010 and decided to set up a collaborative. So we're not an entity. We are a collaborative of organizations and members. And we opened it up. So there was 9 original members to the collaborative we call strategic members. And it is run by the professional organizations, and then we opened it up to associate members, to any organization that felt that they had an interest. So we have many different members. SureScripts was our first member of the Pharmacy HIT Collaborative, NCPDP, Pfizer, Omnicell. I can't name them all, but there are many different organizations that are part of the collaborative. And we focus on pharmacists that provide clinical services, not the dispensing, although we do a little bit of e-prescribing as it relates to the medication order. But we work with the standards development organizations, NCPDP, HL7, and X12, and which is your billing standards. And we make comments public comments to information goes into the Federal Register, regulations. So we work with CMS, HHS, the Office of the National Coordinator, which just had a new name change. They're now falling under HHS and the Secretary. And we also oversee all of the AMA, CPT, American Medical Association's current procedural terminology codes. So we have representatives that attend those meetings to help pharmacists make sure that we have the right coding. We're also the stewards of SNOMED codes, which are clinical terms and codes through the National Library of Medicine's Value Set Authority Center. We have over 130 value sets, and we have probably about 700 terms strictly for pharmacists. So we work with the standards development organizations, especially the terminology ones, ARCS, NORM, SNOMED, LOINC. These are all codings that work. So we work closely with that. We work with USCDI, which is the United States Core for Data Interoperability, to ensure that the coding that we put in place for clinical terms for value-based models will be available. Oh, we do just so much. We really try to support the profession as it relates to clinical services for pharmacists.
Yeah, and just to give some context, when you're out there doing your clinical work, whatever setting you're in, we talk in terms of having conversations with doctors, writing recommendations, doing these things that are very, subjective in nature, but it has to go into something that's more objective in nature, and that's this terminology. How do you, hey, I want to discontinue this person's omeprazole. How does that turn into something that you can process electronically, have that entity on the other side recognize it and pay for it based on what you did or what the outcome was or whatever that is? And that's the piece that I think gets lost on a lot of people, but is obviously critical, because if you can't process, I'm gonna boomer.
It's not Boomer's Day.
It's not Boomer's Day. But if it's not, if you can't do that, you're not at the table. You're not getting paid. So it's critical.
Well, and that's the difference between a fee-for-service model and a value-based model, where you contract with health plans or payers. They're going to want to have clinical interventions. What interventions did pharmacists do?
Absolutely.
So we've worked with and helped create the pharmacist electronic care plan, which is a way to follow a patient for chronic care management. And we just recently are in the ballot procedure for what we call a standardized medication profile that will allow us to have several different types of medication lists so that we can perform appropriate medication reconciliation. These are really important two standards for the exchange of information with the care team and other parts, and the patients themselves. These are standards that are worked on that are all part of what they call FHIR, or Fast Healthcare Interoperability Resources. It's a way of programmers to program pre-programmable, either in JSON or JavaScript, to program into what you would document as a pharmacist as you're providing your clinical services, but it's exchanged in a very standard way that the government has put in the 21st Century Cures Act for interoperability. So they have just a new rule that was released last week. It should go in the Federal Register in August, and that rule is 1,000 pages and names pharmacists 32 times and pharmacies 39 times. And this was the result of the Health Information Technology Advisory Committee, which is a federally appointed committee, had a task force called the Pharmacy Interoperability and Emerging Therapeutics Task Force. This task force, actually, I was honored to be a co-chair of that task force, and we had 34 recommendations go back to the government for pharmacists interoperability in areas that the government should focus on.
That's awesome. Unbelievable.
So if you guys are kind of looking at, all this different data, all these different codes, is there any kind of overarching goals like we as a group want to accomplish, want to see this happen over the next year, 2 years, 5 years?
Yeah, yes, we have a strategic plan on our website, www.pharmacyhit.org, and it goes through our mission and our strategic plans. So we're due to do another strategic plan next year, and we do outline all those areas that we're
Can you share
involved
a
in.
little bit of that, the strategic plan?
Sure. Well, our main mission is to assure that pharmacists that provide clinical services are integrated into the national health IT infrastructure. That means no matter where a pharmacist is, when they do their clinical documentation and work with their system vendors, that we're able to exchange that information in an interoperable way, just like any other provider. And this is very important as we move towards value-based models, because their value-based models work off of clinical documentation, not necessarily I performed a procedure, pay me. That's a fee-for-service type of model. This is a much more comprehensive model that goes into outcomes and is goals related. So we also have a focus on policy and advocacy. This is where we write regulations for the pharmacy profession, and our members can sign on to that or use that information. We have a policy analyst who's under contract with us. We also have 4 different work groups that work on different guidance documents. Work group 1 is working on a paper on value-based payment. There's some very high-level individuals who are very passionate about that area. We also have a coding work group that works on ideas in relationship to coding. We just finished a white paper on deprescribing that is also linked to the reasons for discontinuation, because in our standards work with the standardized medication profile, we also have a discontinued list that also has the ability to be codified with the reasons a medication was discontinued. And we believe that will help with things like prior authorization, reconciliation, getting rid of duplicate therapy, because not only the patients but the other caregivers would be able to see it was discontinued or it was administered in another area and there might have been a failure that occurred with that medication. We have a 3rd work group that works on workflow. They just finished an artificial intelligence paper that we're getting ready to publish, sort of a primer on what's important to pharmacy. We also, then our 4th work group just finished, and it should be published very soon, a paper on interoperability. So this is focused on pharmacists, helping them to explain it, and also for system vendors on what they're going to have to do in the future to assure that they can exchange in an interoperable way, just like if you're working in a pharmacy and you dispense a medication, you go through the different processes and steps of receiving that prescription and then creating a claim for that prescription. That claim is interoperable with an NCPDP, National Council for Prescription Drug Programs, their claim standard, which is a D.0 right now.
Talk a little bit about, I know, the associations all play a role in the collaborative. I've been fortunate to be chair last 2 years. It's only supposed to be 1, but last 2 years.
Thank you.
Yes, and ASCP now convenes the collaborative, which is to say we house it. We collect the fees and the dues, and we pay you and pay the other contractors, and we're proud to do that. We feel like this is important for the profession itself. But talk about one of the things that we did this past year is the SMP project, and we're also very proud of that and being associated with that. And it is something that the foundation, again, has convened, which is good for the foundation because we like to be doing things, especially researches and grants that are moving the profession forward. But talk about that program.
Actually, it's fascinating. I've physically been working on that project since about 2016, when the government passed, Congress passed the Impact Act of 2014. The Impact Act is focused on transitions. During transitions of care, all types of information. And they have a project called the PASSIO project, or what they call the Post-Acute Care Interoperability, PASSIO. And they've been around for a long time, so they've created things like how to exchange advanced directives with patients, especially in the post-acute care setting. What are your cognitive and functional status, which is really important, especially for the aging population during transitions of care. They've just added physical activity, what they call a section of personal functional engagement with the patient. And so mobility issues, gravity, which is social determinants of health. All of that information fits into the FHIR resource or the FHIR standard that will become the standardized medication profile, including the different types of medication lists. We never had the ability to create different lists, so most of our medication reconciliation is reconciling one list to another. So you might take a SureScripts medication list or history, and then you're comparing it with something else. This will give pharmacists the ability to, or systems, the ability to collect different types of lists, lists from the patient, a list that would be specific that the patient wants to keep under control and release their consent for. We have lists for administered in a hospital or a skilled nursing facility. The discharge summary lists or the discharge lists, and this isn't just the name of the drug. This is a fully comprehensive list that includes not only dates and times, well, really dates, but also the full directions for use, the indication that the patient has. So we proved this. We did 2 connectathons. The first connectathon in May was at HL7. It was very successful. We were able to exchange it, and a couple of weeks ago, CMS, Centers for Medicare and Medicaid Services, had a connectathon with HL7. Passio was a representative, and we tested in real time the exchange with an EHR system, not the biggies, but these are sort of systems that sit outside of another EHR, like would sit outside Epic. It was patient-centric services, I think is what it's called. And also Actual Meds tested the medication reconciliation process. CMS was extremely impressed with this work because Passio has had MedRec on their list for the last easily 10 years. And so now has come to fruition. So it is, Passio is overseen by CMS, so we had to go for approval to be part of the Passio use case. And then we also, we were appointed to, or approved to be part of the Passio use case. This CMS Connectathon was really great. We showed in real time how medication reconciliation should really occur, and passed off a summary of different information, pharmacist interventions and recommendations, and then also the medication list, a full comprehensive medication list for pharmacists who, and there was that system was reconciling at the time, and then transferred it to the EHR so you could visually see what they did in real time. It was really amazing.
I can totally see the importance of this because, I mean, transition of care has been one of the bigger challenging, especially coming from hospital to nursing center, and now they're short-term stay, and then they get discharged to home. But, you know, with the senior population rising, I can see how important that this would be to kind of get that connectivity from, they transition to multiple different stages, even within maybe that same nursing home, and how important to keep that communication going.
Yeah, it's not intrasystem, so it's not within that skilled nursing facility or hospital. It's things that are exchanged outside of your system. That's where the standards come in. So if a pharmacy isn't usually inside a skilled nursing facility, so it's an important connection, but also with dietitians, with rehab, with any podiatrists, dentists who aren't really in that facility system, you have to have a way of exchanging information, and this is where the standards come in and the work that we're done. We are due to ballot in September, and we are just finishing one more approval, but we are on the ballot consensus for balloting at both HL7 and NCPDP jointly.
And what does that mean?
That means that once it becomes a standard, it gets listed in what they call the ONC has what's called the interoperability standard advisory. That ISA is where all standards are listed, and then the government takes those lists that are good to go and been tested and or used within a system, and then that is used by the government to put into regulations. So they don't like to put anything in regulations that hasn't been validated or proven for use.
So that will mean downstream what? That when developers are putting their systems together or upgrading their systems, that they're going to use these standards so that they can easily transfer this information and make it quote unquote visible.
So think of a claim, a prescription claim. You receive it via e-prescribing, and that getting it from the physician to the pharmacy is a standard.
Right.
And then your export and so that's an import into your system. Then when you export that you've dispensed it, that information goes into a claim, and that claim is the standard. So your standards deal with outside your system, but you have to have the right data elements and the right fields to capture the information. If you don't, so as an example with the med lists, if the pharmacy doesn't have a place to put multiple types of med lists, they have to build that out in their system before they can exchange these types of lists.
Right.
Because everything's based off of one list. This
Right.
is a reconciled list. This is what my patient takes. I don't know if you've seen anything within your own personal health records. You usually have a list of meds. And so we went to active and inactive. And all these things are international standards for what they call medication resources. It tells you how you can use it, what type of terminology you have to have in it, and then that prepares it for interoperable exchange. And it's really important because next year they're going to start with TEFCA, which is the Trusted Exchange Framework and Common Agreement, where they've created what they call quality, or QHINs, quality health information networks. So think of a QHIN like a Verizon or an AT&T that you have, or a T-Mobile. They're like a connector of information, and so you can do a query blast through a QHIN, and they'll find all of your information that's out there and send you everything. Or you can do a targeted query. I know a patient went to the skilled nursing facility, and now they're going to home care, and so you can target that particular patient information to come into your system. Now, like Actual Meds is what they call a SaaS system, or a software at service type of system, and that, or application, and so it sits outside of an EHR and allows a provider to work within that system, and then you interact with that system through what they call a Smart on Fire app, or an application program interface that sits outside but allows you to view it and do what you want to it. You can bring information into your system like Epic, and that's called what they call a read-write capability. You can read it and download it to a PDF, or you can write it into your system like laboratory information, but you have to have a place to put it in your system. So there's an evolution of what we call EHR-like, or pharmacy management systems, that have to hold clinical data. And this is where we prove that within systems that are out there, like Frameworks and QS1 or Red Sail or Pioneer RX. Those are all systems, and so they had to build out their clinical workflow, because your clinical workflow is very different from your dispensing workflow.
Right.
Your dispensing workflow, you're looking at one drug, following the path of all the way to dispensing and claim and documentation of that one dispensing process. In your clinical process, you're looking at everything on that patient. You're looking at their cognitive and functional status, their mobility, their understanding of medications, and where you can really make recommendations like we do as consultant pharmacists, and making the recommendations. All that can be documented and codified in a way that then can be captured by a health plan for your value-based models.
And that's all coming through like a FHIR type of interface?
Yeah, the FHIR standard takes information from one place to the other in a standard way. so you have a sender and a receiver.
Yeah.
And so if the sender and receiver aren't talking the same language,
That's right.
it's not going to work.
Yeah.
Kind of like Pittsburgh's quarterbacks and their wide receivers.
Right. Exactly.
Just like that.
Just like that.
Well,
I hope it wasn't too technical.
well, no, it's important to be technical because you have to sort of get it.
I don't mind things being over my head because a lot of things are, but this is how we learn and this is how we grow. And I'm so glad someone like yourself is worrying about that kind of stuff, because I'd last about 15 minutes in a meeting like that, and need to catch up. But it's so important, thinking all the way through that in detail.
What I told you is not technical. Okay, so when a bunch of us techie folks get together and you start really designing and talking about it, it's a different level. But it's important that pharmacists understand what's underneath the hood, especially as we move to artificial intelligence. This is critical because artificial intelligence, once you build your algorithm of where that information is being captured and changed, it's sort of like following a path. And if we don't pay attention to that as clinicians and you allow the machine to do the work, this is why I became very scared about using artificial intelligence for medication reconciliation, and why we wanted to do the ASCP project before we really apply artificial intelligence to it, because it isn't just a matter of comparing one list to the other.
Right.
You've got to really have a comprehensive view, and pharmacists should have that information so we could share allergies and our goals related to the patient's goals. It's not just a matter of identifying that this is the patient's A1C. You have to, or for diabetes, you have to be able to work with that patient and document what you're intervening on.
And it's fluid, especially they change settings. A lot of those lab values are going to be very fluid. They're going to be impacted. There's change in therapy. There's change in doses and that kind of stuff. And some of these doctors, especially in a step-down situation, these doctors might interact with that patient for a week or 2 weeks, and then they're on to the next setting. And so, things are changing rapidly.
We call that encounter-based care. So that encounter-based care is where a physician is encountering a patient for a specific disease or condition. Pharmacists are very different. We do more preventative care. So we're looking at everything that the patient is doing that's medication and medication-related information. And if we can't capture that within our systems, how can you do it? It's sort of like going into a nursing facility and doing a chart review. You might be doing that on a computer, where you document. You could be now you should be able to document outside of that system and then send it electronically, so you don't have to log into that EHR and document it there. They would have the ability to bring that information into their system. That's what we call interoperability.
Yeah, and I was just at a seminar with SureScripts, and a lot of the conversations, and this is me, so it's a little pedestrian, but a lot of the conversations were basically around getting credit for what you're doing. So, pharmacists, and I can say this from my past practice as a consultant, like our EHR systems at the very, very beginning, they would tag the attending physician. It could have been the geriatric psychiatrist that wrote the order, but it still fell under the doc. And all of your recommendations, any changes that were made to that patient's profile, fell under the doc. The doc was the one that ordered the changes, even though you recommended them. Ultimately, without your paper, you didn't have the ability to say, I should get credit for that. This structure allows pharmacists to operate and get credit for what impact they're having on the patient. And I think that should make sense to people. We want the credit.
All right.
Well, and there's a couple of ways right now in your fee-for-service model. You're either getting paid because you're dispensing a prescription, or you're getting paid for making a report, like we do within consultant pharmacy system. So you get a yearly or a monthly stipend to do the work based off of your what they call FTEs. But this is a much more comprehensive way in where the future is going. But more importantly, as more artificial intelligence is applied to these types of models, if we're not careful and we don't understand how the machine is being taught, what we call machine learning, and also assuring that, especially for an aging patient, what we call population bias, which is because your algorithms and your machine learning is all based off of evidence-based medicine, and most of the evidence-based medicine and research does not take place in the geriatric or the pediatric population.
Right.
And so if your system is being trained off of those other models, you have to have a way for the clinician to intervene, and we call that augmented artificial intelligence. So in your algorithm, as you're looking at those steps and processes that you take, you stop a specific process. And a good example of that is what radiologists do now. So this artificial intelligence system can look at all radiological images, and then they put it into a queue for the high risk areas. So it does have a human intervention to that, and then it can go on down its path. You never want to see it taking place for a prescribing process. Well, this patient has diabetes, so let's take them all the way to dispensing a medication. That's a big no, because it's so individualized.
Right.
You need to have you could take them to a step of a queue that these are indicators that fall outside the norm, but then for populations such as the aging population, or pediatrics, you have to be able to stop that process and let a pharmacist intervene.
Right.
I'm so glad you brought that up, because some people out there saying, oh, AI is going to take our jobs and that kind of stuff. And there's a lot of fear about it. And then, there's a lot of conversations about the ethics of AI. But at the end of the day, it's a tool. It's a tool that should help us, but not a tool that's gonna replace us. And I don't think we're really ever going to kind of get there. And it's a great example of, that'll help segregate maybe a certain issue, but now we need that clinical pharmacists, trained clinical pharmacists, to intervene and make those decisions. Some of the best consultant pharmacists are able to observe patients too, not just sit in a closet and look at charts.
Right.
Just tell, but go out and watch them during dinner time and watch, talk to the nurses, and how's Miss Jones been what she's been doing, how's her, she's been stumbling a lot, and those type of things that AI is just never going to be able to do.
And that's where clinical documentation on all care team members is really important. But it's not just, the machine can learn better with codified data, because it's looking at a code and not a text-based information. It's harder for the machine to somebody might put a capital T in there, and it has a problem. It can get very complex with systems. So you want to make sure your algorithm is correct prior to teaching the machine through machine learning that leads to artificial intelligence. So we're at a very critical time in pharmacy in relationship to applying machine learning and artificial intelligent tools, especially because of evidence-based medicine that it's based on. Another issue that we found out too, is a lot of the evidence-based medicine sits behind an association wall or an organization wall, and the machine might not, depending on which AI system you're using, might not have the ability or the cost to go
get it
behind the wall information. So it could be based off of poor data, which then is where the real risk sits with artificial intelligence.
Certainly.
Yeah. Well, how long have you been doing this, Shelly?
Well, like I said, I'm almost a 50-year-old, almost 50 years into pharmacy.
Started when you were 10.
No, I'm due to retire. I've been working with Chad to find a replacement for us, so hopefully for the Pharmacy HIT Collaborative, because I believe that the associations in the profession of pharmacy really want to keep this going, because it serves an important piece. When I first started in this work back in 2010, and I'd walk into government meetings and they would say, "Oh, pharmacy's here, great." And I say, "No, a pharmacist is here."
Yeah.
We're not, you wouldn't say, "Oh, a physician's office is here."
Right.
You'd say a physician is here. So they began to understand the term pharmacist, which was really important. And we're starting to see that more. Now, the associations do their own lobbying for different areas and payment and different things that they want. But from a technology standpoint, because it was a newer field, you couldn't find the expertise out there, especially
Right.
when we first started. More coming. And so this is one of the most important things, I think, in pharmacy, or I wouldn't be doing it.
Yeah.
Because I could be doing a lot of other things with my
Well,
life.
I want to go on the podcast and just thank you for doing it. Thank you for being there and protecting pharmacy as well as pushing pharmacy forward, pushing pharmacists forward. I can tell you, coming on as an exec 6 years ago, this is by far the hardest area of my job to understand. You have to invest in going to the meetings, listening to what may sound technical but really isn't technical, to get yourself, on the page of where this needs to go. So we rely on Shelly. I'm proud that Shelly is a ASCP past leader, president, and has led this for the past 15 years. So, yeah, absolutely. And we are moving forward, but it's kind of like Arnie Clayman is also sort of stepping back a little bit. But he's not going away. You're not going away.
No.
We need you still.
Not going
The
away.
new person will need you, and the profession still needs you. So thanks for being here today.
You've lived in Chicago, Louisiana, Nevada, D.C. Like, what's left? What part of the country
Las
that you
Vegas.
need to?
I've been all over the world, and I just want, we're very simple people. We've done traveling all over, and so we're just, I'm very passionate about my profession, but I have a reason for it. I have a great niece who's a pharmacist. My daughter's a
yes.
pharmacist. My son-in-law is a pharmacist.
Wow.
My daughter was on the board of ASCP.
Right.
She was a resident of ASCP. And so these are all, it's important to me that the profession stays on, because when I first got involved in it, I was very worried that the profession would not be here.
Mm-hmm.
Because we can't continue to just dispense medications.
Right.
We have to be paid for our clinical skills.
Yep.
And so what we do is we write use cases of examples of patients, like when we did the Connect-a-thon with CMS and HL7, we had a use case for Betsy Smith Johnson, who's a very complex patient and on multiple medications, and she has multiple chronic conditions. But it's not just pharmacists. You have to be able to integrate with others of the care team who are using different software and different workflows. And so the only way you can do that is by exchanging it with the standard.
Wonderful.
Well, awesome. Thank you for being here.
Oh,
Thank you for being in person.
And they not falling down the job like Boomer did a couple of times.
Yeah, right.
So.
Right. All right. Well, thanks, everybody. This has been a great podcast. We'll see you on the next version of our experience.